Hi, welcome to the next in our series of podcasts, Action on Health Inequality. Last time we spoke about the importance of why this work matters, and today we'll be taking a deeper dive into training, what the tools we need are and how we can continue our development. I'm Ruw, I'm a geriatrician and I'm Director of Health Equality and Inclusion at University Hospitals of Leicester. Aicha.
Hi everyone, my name is Aicha Bouraoui. I'm a rheumatology consultant in Lewisham and Greenwich NHS Trust, and I'm also honorary consultant adolescent rheumatology at UCLH. I'm one of the content advisors in Medical Care Driving Change. It's my great honour to be part of this action against health inequality.
And I'm Katie Malbon. I'm a general paediatrician at Imperial College Healthcare NHS Trust. I have a special interest in adolescent medicine, and it's great to be here.
Thanks for being here, both of you. So today I thought we'd start by thinking about our training and how we've got to where we are today in the context of health equity, how we've developed as practitioners, and how we're helping others to develop. So I was wondering if, Aicha, you could maybe start by taking us through your personal journey of learning and the things that you have picked up as helpful towards developing.
Really good question, Ruw. When I started my training, my high specialty training as an ST3, so I was really interested to learn about the biomedical aspects of my specialty in rheumatology. I was also doing general medical training in geriatric medicine, and I have seen the contrasts in the way how my specialty manage health conditions, although I felt rheumatology is a specialty that deal with multi-system disease and is more holistic. But I saw the contrast with the geriatric side where I was doing the falls clinic with my supervisors, and after that I felt my care is more holistic at that point. And I really enjoyed working on both specialties because at that point I was quite early in my specialty training, really keen to learn about how we diagnose conditions with complex multi-system diseases and how we manage them and target those diseases in specific aspects of the immune pathway. But in contrast, there was also the geriatric aspects of it where we see patients as a whole in their wider psychosocial environment. And I felt the MDT input is more practically beneficial to the patients. Toward the end of my ST3, I had my end of year appraisal with my supervisor, and he was geriatrician, but like he was doing my general medicine appraisal. And he asked me a few questions about the NHS, and I didn't answer any of them. And he felt that, looking at my portfolio, he felt that I made a good progress clinically. I've done lots of CBD and work-based assessments in my specialty, and he asked whether it's time actually take time out of my clinical training to learn a bit more on the NHS. And I applied for the Darcy Fellowship, and I was very lucky to take part in this. But that was an eye-opening experience for me at the start of my high specialty training. So I learned about system thinking, I learned about co-production and how we work with patients as equal partners. And I also took a step further and I got involved with the Institute of Healthcare Improvement, took part in leadership program and started from a learner to mentor and then coaching. I did coaching fellowship. But the whole experience, what it taught me is that there is a lot that we need to cover as part of medical training, and it's not covered. When I went back to training, none of my medical training, which I more than doubled because of less than full-time training with my family, circumstances and everything, I worked most of the time 60%. But despite that lengthy training program, none of my training days, none of them covered the psychosocial aspects of care. And when I tried to implement that as a trainee, it was really hard because I look different. My approach is different. Health coaching didn't exist as a concept. So it was really hard for me. Now, as a new consultant, one of my goals is any change has to start with myself. So I need to start in a new way, how I can support my trainee to see the whole person, even if they are specialized in rheumatology or in the most kind of uncommon conditions.
Thank you for sharing. I mean, it's such a fascinating journey that you've been on, but it resonates because certainly from my experience, the additional training that I've done has felt like it's been in my time, on my terms, and I've recognised the need. Katie, is that something that you identify with as well, especially in the context of health equity and the wider determinants?
Absolutely. So I was at medical school over 30 years ago, and I can honestly say I don't remember being taught anything about the wider social determinants of health. I think it probably became apparent to me sort of subconsciously during my GP rotation, when I started to see that the patient actually had a family. And actually I had experience with a GP just outside Manchester who'd been a GP for years and knew all his patients and knew their whole families. And so he talked to me about, you know, why this patient was in a certain situation and how their treatment was more sort of geared towards what was happening, you know, in their wider life. And so suddenly I sort of got quite interested in that. And I actually thought I wanted to go on and be a GP for that very reason. But then once I qualified, I took a different turn and decided to do paediatrics. And I think, again, I was quite sort of, you know, focused on the specialty. I mean, paediatrics is in itself a specialty where we do look beyond just the patient. So I guess I was drawn to it because of that. But I do remember a particular time when I was doing an audit looking at teenagers who had actually come for an assessment following sexual assault. And I was looking at factors around that incident. And I realised that many of those sexual assaults had been under the influence of alcohol. And that's when I sort of started to get interested in adolescents and think actually there were so many things happening in their lives which are determining, you know, what happens to them, the risk that they put themselves in. And it sort of, I became fascinated by it. So I was sort of drawn to that way of thinking about the patient not just being the sort of medical thing, the fracture or the condition, but there was much more surrounding that patient which put them in the situation that they were in. And then my training took me to the States, where it was really, really stark in terms of systems and inequity of care. So there you're dealing with patients who, if they don't have health insurance, they can't have certain medications or treatments. I was fortunate enough to work in a situation where patients could come if they didn't have health insurance or the means to pay, and it was a sort of non-profit health centre. But it really, you know, it was so sort of real that I saw everything that was going on in that patient's life. And this health centre was amazing because they could come in and they could have all aspects of their life sort of addressed. So from their education, from their nutrition, from their career plans to their actual health condition. And that really sort of made me think we should be doing much more of this in the UK.
So again, and it's so fascinating to listen to, but what I'm hearing is that you had an opportunity to take yourself outside of the construct of the NHS, and similar to Aicha, when you do the Darcy Fellowship, although it's still in the UK, it's outside of day-to-day practice. And I'm just thinking about colleagues who might be listening, thinking that I don't have that opportunity, or it's not happening for me right now. What can I do today? So in terms of developing in this area, so, you know, improving knowledge or skills around the wider determinants health equity, are there any tips that you might think of for trainees or colleagues who are consultants, and how we start to bring in some of this into our day-to-day practice and develop?
Yeah, so I mean, obviously it needs to really start in medical school, but I think there's something quite difficult in when you're a medical student not really understanding the context. So if you're sitting in a lecture theatre, I think it's very hard to understand what it actually means that we're being told. Actually an initiative that happened in the States with some of the medical students there, I mean, they were fortunate enough to have a sort of whole adolescent medicine rotation. But during that time, they did a long-term clinical experience. So they actually got to know a patient, and they would go with that patient to their appointments, their medical appointments, but they would also arrange to meet that patient somewhere in the community to sort of catch up with them and learn about, you know, how they're managing their disease, what the difficulties might be about getting to appointments, what else was going on in their life that was impacting on them, and maybe interfering with their medical treatment. And they would do that over 6 months. And some of them actually went on and carried on sort of having a relationship with that family. And then they would write an essay about a certain aspect of that experience. And I think it was really valuable for them going forward to have an understanding of not just the patient, but the family and everything that was impacting on their health.
Yes, so I think in there's something around how you line up your day-to-day practice with actually recognising that in the context of lived experience and what that means. And through that, you develop that experiential learning that is so crucial to being a medic, a doctor or a clinician. You develop those skills and grow from that.
Totally.
And if I think about the things that we have to do on top of that, so for example, quality improvement, audit, etc. Aicha, have you got any tips on how we can start to do those through the lens of equity so that you're embedding it into the system, but you're also developing those skills and improvement as well as you go?
Thank you, Ruw. It's a great question, and it's challenging time for the NHS at the moment and for our workforce. And to me, yes, we know there is a challenge. The first positive aspect of the challenge is we know there is a problem, and we know that each one of us has a role to address the problem. So the first step of actually embedding equity is realizing that there is no equity on the system, realizing that we are not training future generation and we were not trained properly to address equity. So understanding there is a problem is the first step for a positive journey. And the next step is thinking collectively together as a team, so breaking the silo. So in a positive mindset, I'm not on my own here. I'm not the only one who is not addressing the challenge that my patient is facing. All of us are part of the solution. So reaching out to your colleagues, to your MDT, have a chat, have a coffee, and just think together, how can we support our patient collectively? And then by taking joint action, which we are doing now in the college via Medical Care Drive and Change, is collective action to address health inequality. So the first step is, addressing the problem collectively and reach out to those who have the same passion about addressing health equity in medical practice, and think about what resources are available already in your system. Instead, start with one step at a time and test it through the lens of quality improvement and see whether it will embed it. I can give you an example of quality improvement we are doing at University College London Hospital, where we are looking at addressing health inequality and social determinants of health that get in the way of people and young people coming to clinic. And in this quality improvement project, we started with data first. So we looked at our clinic non-attendance data. And what we've realized is patients who live far away from the hospital and those who live in the most deprived areas are likely not to attend their clinic appointments. So we demonstrated with using data that health inequality is the barrier that gets in the way of people coming to clinic. It's not people just not turning up. In a normal traditional system, what happens after 2 clinical attendance, you end up discharging the patient, which means we penalize the victim of the structural barriers that get in the way of them accessing care. So realizing that there is a problem, we had to go to the next step to work collectively together to address this health inequality issue that gets in the way of people accessing care. And we worked collectively as clinicians, as well as working with our trainees, with our improvement team, and most importantly, with patients using the service. We developed an organizing committee for the projects, and we had a regular meeting to plan for our project strategy, looking at qualitative data that help us to deep dive into aspects of health inequality that get in the way of people accessing care. So we had about 3 work streams. The first work stream was to contact young people who are already not attending clinics, and we co-produced a script along with about 10 questions to ask these patients about the different barriers that get in the way of them accessing care and what health actually mean to them and what staying well mean to them. And we got our trainees calling patients. So it was a good experience for them to actually, probably for the first time, to speak with patients about aspects of their care that affect over 50% of their health outcome, and they are not covered in their practical day-to-day practice. And so our trainee Rasheen really enjoyed doing those interviews, and we collected data, and thematic analysis showed that poor communications, and that include language barriers along with poor rapport and relationship building with young people, and as well as actually sending clinical informations and appointment to parents rather than to the young person directly, made them feel not being involved and also not having access to the team that actually embed holistic care when it comes to their own care. But the second challenge was travel, and many young people reported financial difficulty traveling to a tertiary centre, and that was one of the main structural barriers. Similar themes came out from our engagement strategy in the next in the work stream, where we had an engagement event with young people, co-produced, co-facilitated with young people themselves. We called it Hangout Space. And during this workshop, the same theme around poor communications as well as structural barrier. But during that event, we had a fantastic also session where young people engaged with healthcare professional in the afternoon session, and we did training simulations where the young person became a healthcare professional, and the healthcare professional was in the shoes of the young person. And we had different scenarios, from administrator calling a young person to book their appointments, to a pharmacist talking about medications, to a physiotherapist talking about exercise and home-based exercise programs. And it was really interesting to give a message to healthcare professional how much jargon we use in our clinical practice and how can we make holistic care happen in practical terms. And the third work stream is engaging with our community, because as a healthcare professional, and as a healthcare organization, no matter how big is the institutions, we need to engage with our community to understand the cultural barrier that gets in the way of people trusting the system in accessing care. And our recent work with schools, we had a workshop in the school, and a student co-designed with us community-based survey, and in a few weeks' time they will present their finding to us at UCLH.
It's amazing work, but I think actually the thing that strikes me from it is what you're describing doesn't feel alien to me as an individual. So if I'm feeling some of those challenges when I interact with healthcare, then imagine some of the challenges that our patients are experiencing. Katie, thinking a little bit more about that, so we're experienced doctors and we have learned through doing, but there is so much more left for us to learn. What do you think now, as a practitioner, as a clinician working in an MDT, the things that you need to focus on to continue that development and that learning, and how can the system start to support some of that?
Yeah, it's a great question. So, I mean, I think what I've noticed that really helps patients is communicating with schools. So I think as paediatricians, we should be working much more closely with education. And simple things can be overcome by everybody understanding the patient's condition and how that's affecting their life. And there's something about bringing together everybody in a meeting with school, the patient, the parents, the other professionals that are involved in that young person's life, so that everybody understands what is important to that patient and what will make a difference to them. Because quite often we just don't know. And you learn so much more once you understand what that patient is like within the school. And also I think for teachers, it's important that teachers understand how that young person's life is being affected by their condition, and has a bit more of an understanding of what that condition will mean to that patient. And then they can adapt and have more empathy, I think, with the patient. So that's a first step, and that's quite hard to quantify how important that work is, and it's very time consuming. But I think in the long term, it's an efficient use of time, and will prevent patients coming back to hospital for both appointments, but also presenting to the emergency department.
So for me, that's 4 simple words: what matters to you, and it doesn't really have to be more complicated than that. But that's a really good reminder, because when you're busy in clinical practice actually focusing on what matters to you as a patient, as a person, it's really easy to shelve it and think about the other things that you've got to get through. So I think that's a really important message.
Absolutely. We had the same message when we did the simulation training, and what young people told us, it doesn't take you a long time to build rapport with patients. Just look at them and say, how are you? What matters to you?
Yeah.
And that's really key to build that relationship, build trust with them.
Yeah, so thinking then about how we start to bring all of this together, because I think what we've described is that actually we've all been on a learning process. We're still on that journey and we've got a lot more learning to do. There is a lot more that needs to come in terms of how trainees experience training, how we develop as clinicians, as teams, as leaders. But if you had to give people one take-home message of how do you start to learn, how do you start to grow in this area, in the context of health equity and wider determinants, what would your top tips be? I'll start with you, Katie.
Well, I think I'd be telling trainees, medical students, to be inquisitive and to ask questions. So, I always say to them when they're starting off in the rotation, be a detective, don't be embarrassed about asking the questions. Really understand what home is like, what school is like, what else is happening in that young person's life. And what might be impacting on their health. And I think that's a start.
Perfect. How about you, Aicha?
So for me, I think it's important that we empower our trainees. We realize collectively together, whether we are trainers or trainee, that the system is not perfect, and we need to work collectively together to support patients holistically. So we need to empower them to be curious, to set up their learning goal. How can I embed holistic approach in my day-to-day practice, and test new ideas as you learn and grow? We are all learning together, and also empower them to criticize me as a trainer. If I miss anything, then they can actually address that, because that will help to build confidence and trust, and also make them feel more empowered. The last probably tip that I would give is be a role model, and just try to remember that you are not just addressing care for that individual patient by listening to their whole story and what else is going on in their lives, but also you are helping to develop future generations of doctors.
Amazing. So for me, I'm hearing there, be a detective, empower your trainees, and role model as top tips. And for me, there's something about recognizing that we are all learning, we're going to get things wrong, but we have to do that together and collectively. So it's been really great to talk to you both again. For more information, please come to Medical Care Driving Change at the Royal College of Physicians.